name is Mark Harbroch. I am the Director of Policy for HFA. I've been part of the advocacy team since 2019. And as most of you are probably aware, I see many familiar names on here. HFA member organizations are very independent and autonomous from HFA. Our advocacy teams, we work really in partnership with the member organizations to support their advocacy efforts, provide them with any tools, resources, training that they need or request from us to help their members become better advocates. And that's not just with policymakers. That's with health insurers or employers, at school, wherever need be. Now, these needs, they can vary greatly depending largely on the staffing, the experience, the resources of each member organization. In some states, we may have very little interaction, and that's fine. In other states, I may be talking with them every week or two, and that's fine as well. So it really is dependent on the needs of that individual member organization. There are states, Florida's one example where I'm based. We may even take more of a lead role in helping to identify or define specific policy priorities. We'll organize and lead teams on a state capitol day. We'll participate in the stakeholder or advocacy ambassador programs or other events that go on throughout the year. And very often we are asked by the state member organizations to provide handouts or policy briefs or any other type of training resources, or even to put on a webinar or other presentations about, for example, how patients can appeal denials, access federal disability programs, even ensure that their legal rights are protected, whether it's in the workplace or school setting. Now, in my experience, covering well over 20 states for HFA over the last 5 years, there's probably a few critical factors that I wanted to highlight that really tend to define whether MOs have an effective advocacy program in place. And a couple of these are probably obvious, maybe not. One, it really helps us to have a staff person that is dedicated to advocacy. That can certainly be the executive director. Very often that's the case. We have some very passionate EDs with some extensive advocacy backgrounds who are really committed to doing that. But frequently, if they're, EDs can have many different hats to fill, many different roles that take their time. So if there is another staff person who is dedicated to advocacy, that can really help. The other is to have regular scheduled advocacy meetings, not just around the state capitol days, throughout the entire year. And that really can determine how effective your advocacy program is, because there are many needs and opportunities that arise outside of legislative sessions, especially if you're in a state like Texas that only has a session every other year. And so it's really important to foster relationships either with lawmakers in their district offices or state agencies like Medicaid, Department of Health, Insurance Department, et cetera. Now, the third one that I really wanted to highlight, because it's so relevant to what we're talking about today, is open and frequent communication with their local hemophilia treatment center staff. This one is really critical to identifying emergency access barriers, things that we may not be aware of that are coming up, especially by those faced by underserved or marginalized populations. And that's because HTC staff really are the front line or the first point of contact with a wide range, a diverse range of patients that national or state bleeding disorder organizations may never encounter otherwise. So the HTC staff really are by far the #1 source of patient stories for us. For a number of our advocacy initiatives, whether it's copay accumulators or other type of insurance problems that their patients are having. Very often they will bring to us something that we weren't aware insurers were doing. As many of you are aware, when we're dealing with advocacy at the health insurance level, it's often a game of whack-a-mole. We really focus on preventing one cost containment strategy that they're doing, And while we're doing that, they're already ahead of the game doing something different. And the way that we find out about it most often is through staff at HTC bringing that to us. And so really important that you have open and frequent communication line with your HTC and vice versa. And now the pandemic really put a spotlight. One thing, really important thing I want to say before I move on. HFA, because of how critical that line is with the HTC staff, in recent years, we've really tried to increasingly provide advocacy trainings directly for staff at hemophilia treatment centers, and we've really encouraged member organizations to do the same. The Medicaid Unwinding webinar that we put on last year is probably one prime example that really helps HTCs better identify when patients are having certain problems and know to use us or their state member organization as a resource for their patients. Now, as I was mentioning, the pandemic really put a spotlight on a lot of the barriers to care that were out there for underserved populations. One example that I can highlight is the expansion of telehealth. That helped many patients of ours, especially in the states that I cover that have some very rural areas and have to drive, easily 4 or 5 hours to an HTC, help them to be able to continue treatment through things that didn't necessarily require an in-person visit. For example, teaching or monitoring how to self-infuse. Patients, who couldn't afford that travel or didn't have access to the internet or couldn't afford internet, obviously they couldn't take advantage of the telehealth services. And so that remained a barrier and one that we're really focusing on. So I look forward to hearing, many other of those type of examples that may be discussed today. And just wanted to give a shout out to Adrian on our staff. Many thanks and kudos for pulling this together and leading these really important and timely discussions. So thank you again, Adrian.
Thank you so much, Mark. And now I will bring in Melissa Compton and Sue Martin to discuss the member organization perspective. Please remember that today, the goal is to discuss about solutions and see how we can bring together HTCs and member organizations in a way that addresses barriers that we found in underserved community members in the bleeding disorder community receiving care. And the fact that health equity concerns affect us all. And that can be expressed in a multitude of ways, whether that's geographic distance to treatment, whether that's racism, sexism in care, or whether that's just financial burdens and toxicity. Thank you so much. And I will now ask Melissa and Sue to unmute. Great. If you could give you guys yourself an introduction, we can go into our question section.
So you want to go first?
I'm the executive director of the Lone Star Bleeding Disorders Foundation in Texas. I cover the southern half of Texas, so Houston, San Antonio, Austin, all the way to El Paso, and then down to the Rio Grande Valley. I have a 21-year-old son with hemophilia, which is how I got involved in the chapter, and have worked for the chapter for about 16 years, but been executive director for 11 in a few weeks here.
Okay. Yeah, so I'm Sue Martin. I'm the executive director of the Bleeding Disorders Association of South Carolina. I have been in South Carolina at the chapter for almost 30 years. I have 3 kids with hemophilia. They're about 28 years now, so it's been a long ride. And I have been at the chapter here 20 years, and then as executive director, this is my 10th year. So thank you for having us.
Thank you so much. I'd love to start, I guess, with some, targeted questions before going into general questions and give you both an opportunity to, bounce ideas off one another. We also have Mark still on in case anyone has any questions for the national perspective. But while Sue and Melissa are, speaking, please think of any questions and think about how their responses about their own programming maybe relates to how you've seen care handled in your own state, or how you've seen programming change. So I guess to start, I'd love to ask Sue, looking over your own work, especially with developing programming like support groups and targeted community, efforts like that. How would you describe the process of developing a community engagement plan or program? How would you describe how that process has been and how it has kind of impacted the way that you operate at the chapter level?
Okay, thanks, Adrian. So really thinking about this question, we start each year, like many of my chapters, I'm sure my colleagues, we start probably in about September, start thinking about what we've seen throughout the year, what we've learned, which areas in which membership has grown the most, or who needs, has reached out and said what kind of work or what kind of support they need. And we start thinking about what we're going to develop for the year. And we start about November sending out a needs assessment to our community. And really it's a feedback, a needs assessment, a feedback, just kind of how we're doing, what do people need, want, what could we eliminate, what do we do good, who needs more help, things of that nature. And then we always leave it very much open-ended so people can, go ahead and put in whatever they want. And that's kind of how we start with what we see where our membership states. And a lot of times, like this last year, we had specific questions like, is programming needed for our women? Is programming needed for our low income? Is programming needed for our older gentlemen? And we kind of start with that and then start developing those areas. And this year, our biggest targets were our women. As we all know, women are having, many issues with getting access to care and making sure that they have treatment and treatment plans and that they can see at HTC. So our women have been very much on our minds. So we've worked a lot with developing programs around our women. Our VWD, the same thing, trying to make sure our VWD membership has grown immensely. Since we've not necessarily, well, probably because we changed our name to Bleeding Disorders Association, they felt a little bit more inclusive and kind of our arms wrapped around them, even though we always had and have had programs for our VWD. We've really tried to take that area and develop it a little bit more. So any and everything that we do, we have a VWD session so that those individuals get some targeted education because they're still lacking in the education area and treatment, in our opinion. We looked at our Hispanic community. Our Hispanic community, we do not do a good job. I am the only employee. I have a part-time, or not even a part-time, less than part-time engagement coordinator that does my social media and things of that nature. So I'm very limited, and we're limited with funding. So our area of our Hispanic community does not receive, we've reached out and we tried, and we've had some programs in Spanish, but I wish we had the opportunity to have a Spanish speaking person on hand, or when I get a phone call and I need to talk to them. We had that just the other day, and the individual on the other line did not speak any English. There was nobody there. So I felt like a failure because I could not communicate with this wonderful woman. But these came from a treatment center. We kind of pushed that back to them. And then we have our older gentlemen, which are and very much underserved, and those that are disabled on disability and low income. It's hard to get them. We don't do a very good job, but we do reach out. They know they're welcome, but getting them together, it's hard because we serve the whole entire state. So getting those guys together, having that opportunity to come together, to be engaged, that is a struggle that we do have. And then we have our Black community as well. We've worked really hard with making sure that we meet their needs. And there's some real struggles being in the South and feeling inclusive. So that has been a real area that I've really put a lot of concentration into.
No, I really want to focus in on that idea of a needs assessment and that kind of that process of feeling out what the needs of the community are, especially with, you know, the fact that you said limited resources. You have one not even part-time staff member. You know, Melissa, looking at your organization, I traveling across the country, I've been part of those needs assessment meetings. I've been part of that process, you know, listening to each state's individual you know, path they take to finding out what the needs of the community members are. I'd love to see how that compares, you know, for Lone Star, and whether it's a similar process, if it's the same level of, you know, like same amount of repetition of, you know, that needs assessment every year, um, just to get that comparison.
Yeah, sure. I mean, I think a lot of what Sue said applies here in Texas. You know, we have a lot of those groups. Most of our focus is on the Spanish speaking population here. But yeah, we do a lot of the needs assessment. We have a lot of conversations with our HTCs as to what the needs are, and then even our community at events. You know, just asking them what they need, because we may think they need something and be totally off target. So yeah, we rely on those a lot in Texas as well.
I was gonna say
Yeah.
those verbal conversations with the members, I think is probably even bigger. And I'm sure we all do the same thing. It's just, you know, as you're sitting around, you're talking and someone will say, hey, we need this, or I didn't understand that or something. So there's a lot of that engagement that comes from conversations that we have that are live. And I think that's where we get a lot of what is necessary and what is needed.
And some, I kind of relied on that when we've created our support groups. You know, our Hispanic support group, I did not create that. I had a community member that was very involved that is Hispanic. I'm like, I need you to take the lead on this, you know, with my support, and you tell me what the community needs, because I may do an event that they are totally not interested in, or, you know, what topics do you need? Rely on the HTC as well. What topics do these, what kind of education does that group need, rather than just relying on what I think.
And it's good when you say that. It's good to have the conversations with somebody that is Hispanic, because I didn't know a lot of this. Well, and I probably knew it because I don't receive that when I get the information that they don't. A lot of Hispanic people don't, I guess, like to email or don't use email. I'm not sure what it is, but they're texters, and so I had to learn that. Oh, well, sending out an email to them, they might not get it, but if I text them, you know, no problem. So I think it's things that you have to kind of learn some of the different cultures or what people are able to do or what they like to do, and work with that as well.
And I guess for both of you, how would you rate the importance of you know, translation or Spanish supported events as part of your outreach? So especially for you, Melissa.
Yeah, it's huge. So we are very fortunate, and I think some of the other chapters have used her as well. We have a live translator who translates a lot of our documents, but she comes to our events. So like our big state conference is 100% live translated. We have a set of headsets, and she stands in the back, and she's got the medical background, so she doesn't have to pause when, you know, there's a presenter up there presenting some sort of medical jargon that if you just hire a translator, they're like, wait, I don't even know what these words are. So live translation, and that's huge to get them involved and feel like, you know, their live time. It's not, you have to say something in English and then Spanish and English and Spanish, or in English, you know, completely and none. But that has helped a lot, but that is huge. And we've tried to translate, you know, we started with events, print materials. Now we're into our website and things like that to get those things translated.
Yeah, that's great. We don't have that. I use Rigo on here. I don't know if he's on here, but when we sent out something our first time that we did it all in Spanish, I had him translate it for me. And so, you know, utilizing what resources I had, you know, was great. But we've had two very successful events, all done in Spanish speaker. And then we also translated a little bit in English because we wanted also it to be a community feel. I'm really big into that, even though if I target an audience like the Black community or Hispanic community, I want the other community members to know that they're also coming and embracing that community. So some of them, you know, came and listened in Spanish, but then we also had a side translation, a little bit of English. So we were all kind of together. It was kind of fun, and everybody felt like one big family. But we don't have a lot of Hispanic events like Melissa and some of the other chapters that have the larger population. We work with our HTCs side by side, and just even on our database between the two, we probably have maybe 20 families that we've identified in the state, and there are a lot more than that. So I'm not sure where they all are or why we're not capturing them, but that is an area that we need to work harder on.
No, definitely. I guess, looking at the idea of hurdles, have there been any, what are some hurdles that impact your ability to help underserved communities, specific to your own states? Melissa, for example, are there any hurdles that impact your efforts specifically in reaching Spanish-speaking communities in Texas?
Yes, I mean, a state the size of Texas, there's hurdles in reaching a lot of people. But a large portion of our Spanish-speaking community lives down in the valley in these little small towns. And by the valley, I mean the whole little bottom part of Texas. So it's a large area. You have one event and they still might be driving 2.5 hours to get to you. El Paso, all down in the Big Bend area. So very rural, internet access is an issue. So yes, getting to those people is definitely a hurdle.
I guess, and what's the comparison in South Carolina for you, Sue?
So, yeah, so we're not as big, obviously, of a state, but we, being the only chapter that serves the entire state, we try to do, I try to center a lot of our work in the mid-state, which is in Columbia area. So if you were coming from the upstate or you're coming from the low country, getting to the middle of the state, can take maybe, well, if you're way down at the beach, it can take 3.5, 4 hours. And then I kind of work down that way as well. But I did find that in the last 2 events that we had with our Hispanic population, if we are driving more than a half hour, they chose not to come. So I think that was, and that's with a lot of groups as well. But I think that was one thing that, became apparent that I need to try to, and I circulate in different, like I said, our state is the upstate, the mid-state, and the low country. And I try to circulate and do events with different communities and different things in each one of those regions. We have 3 regions, that's what we call it, and then outside the regions. But being able to travel, being able to get there, being able to have funding to put those together, a dedicated, I mean, I can go on and on with the hurdles. A dedicated staff person would be awesome, and some outreach, but there's just not enough time in the day. But we do work with our treatment center, and they do identify patients and provide them to us. And then, we do the same back to them.
Yeah, specifically when I was at one of your events last year, I actually remember there being treatment center staff, I think, serving on a panel.
Yep.
And
we do, I will be honest with you, and I don't know if this conversation is different or where we're going here, but when my children were diagnosed, now that was like almost 30 years ago, so things are very different, very different. We were very much alone and no history, and I was absolutely frightened beyond means. I had one child, and then he started bleeding from the kidneys, long story, and then he was an identical twin, and then I had another child, and I had 2 more. So out of my 5 kids, 3 instantly became children with hemophilia. So it was a huge fright for me, to be honest with you. I was very scared. So when we met with the treatment center for the very first time, when we finally landed, we landed in Colorado at that time. We had Marilyn Mink Johnson, who was the greatest of physicians. However, between the treatment center and the chapter, there wasn't unity, and it wasn't anything really terrible or anything, but there wasn't unity, and I felt that, and I thought, oh my gosh, both these guys should be providing me everything I can, because I needed my treatment providers, but I needed everything that the chapter could provide for me. And if there was not a synergy there, then how are they helping me? So when I became involved, I became involved there, but then I've done that all the way through. that was my number one, was our treatment centers, whether we like each other or not, we better work together, because we need to work for the people and for the people that we serve. And so when I landed here in South Carolina, that was the number one thing that, and I became the executive director, years later. I said that was the number one thing that we need to do, is if we're not jiving or if there's something wrong, we need to fix that. And so our treatment center is at every one of our events. They are always welcome if they have time to come. All three of them. I have them almost on every panel, everything that we do, because I want them to know what we do. And then, we're a referral to each other. And I can go into that later, but I think if you have that ability to find, and I can tell you that in time, what we did for that, because it wasn't an easy thing to get to the point where we are now, but we have a very good respect for one another, and it works really good for everybody.
No, it's really amazing. I'd really love to, get I know Melissa was responding to Omar about, the in-person translation, which is really, really important. I'd love to hit on that after, getting your perspective on that HTC relationship and what your own experience has been like, Melissa, in creating that relationship, and your experience with your HTC as an ED, but also as, the mother of a bleeding disorder patient.
Yeah, I mean, it's very similar to Sue. We work side by side with our HTCs all the time, events, communication, assessing the community's needs, kind of everything Sue said. We work very closely. We really value that relationship.
I guess moving the conversation to in-person translation, it really makes me think of kind of a question there's been on the physician end of it, of, working with caregivers and family members of Spanish speaking communities. The idea that for certain communities, like Spanish speaking communities or non-English dominant language speakers, the idea of family support and family inclusion is incredibly important. Your family unit is one that helps you with things like translation services, with interpretation. The idea of bringing in these translators into events, I think, is incredibly useful, just because it has the ability for that person who's attending the event to have the same experience as someone else. It's the idea that someone that speaks Spanish, or someone that's not as proficient in English, is able to have the same opportunities that someone that does speak English. Or, if we want to compare it to the fact that, when you go to a government, center, or you go to a local government office, there'll be a large number of brochures or materials available in English, right? So much so that it's almost too much. And it can be annoying, parsing all through the papers and dealing with the sheer amount of literature. But if you compare it to a community member who's not English proficient, they have no paperwork to parse through. They have too much information to deal with. And the worst thing than having too much paperwork to deal with is having none. So that idea of in-person translation is so important for these people who maybe don't have the same level of English proficiency. How did you guys start with that, that process? What kind of set off that discussion for you, that you wanted to have in-person translation, or you wanted to connect with this, individual?
So we've had Mary for a long time, our translator. She works in a hospital setting, not directly at the HTC, but so she does a lot of translation. Our HTC actually is one that found her for us. And I mean, we have such a large population of people who either wouldn't come to an event, or would come but would not know what was going on, or, like you said, someone in the family's in English and they're over there whispering, what they're trying to say, and that's gets distracting, and then they're behind, and then are they really able to listen because they're trying to translate? So yeah, it was just a process of putting everything into place, with finding Mary and finding the headsets and putting it all in place.
No, that's amazing. Yeah, I agree with Omar that, a lot of Spanish speaking families rely typically on their young children to do their best to translate, documentation for their parents. As a first generation immigrant, I definitely experienced that, and the kind of teamwork aspect of you're dealing with a problem as a family unit, and the person who has the best English proficiency, which oftentimes is the youngest child, has to take on that burden, or that work, which, like you said, Melissa, can really lead to that question of is everyone really receiving the information? What happens if, let's say, the child who has the bleeding disorder is the one that's serving as the family translator? I guess, working off of that, I would really love to ask, you had your connection with this person, Manny,
Mary.
Mary, done through your HTC. Has there been any other ways that you've integrated your HTC into your work, or services they've helped you with?
Oh yeah. I mean, like I said before, we are like Sue, we work hand in hand with our HTC, and they are at events, they serve on panels, we meet with them several times a year to talk about community needs. So yeah, they're very involved in our chapter. And then we say, what can we do to help you as well? So two-way street.
We have a lot of conversations with them on really weekly, whatever. If I have a problem with a patient, or somebody calls me, I'll say, hey, this person doesn't have, they can't get in. I had a lady the other day that literally she was bleeding, just going on and on and on. And she kept texting. I said, you got to get to the treatment center. You got to get to a treatment center. Where her insurance, number one, wouldn't allow her to go there because it was, let's see, this was a new one. Every day it's a new one. The doctors are pediatric, and she would be referred to an adult hematologist, but the doctors are pediatric in our treatment center. So her insurance couldn't understand why she would be needing a referral to a pediatric hematologist. So it went on and on and on. Finally, I said, I just call them. I say, you need to see her and see what you can do. And if there's something, we have a deep understanding that if they need something financially, I'll pay for it. I have a financial assistance program with them. And I do all the work. And if they have a patient that, like this woman, if she needs to be seen and it's going to be outside, we work on what would be like, what's the cheapest that you can get her in, send me the bill, I'll pay for it if she can't pay for it, things like that. So, doing infusion clinics, there always are infusion clinic nurses and our nurses at our camps that we go to. So there's I don't know how I can do a lot of things without them, especially when we need them for things, or what issues we're having with insurance. What are they seeing? How can we get our patients seen? It's a great relationship to have side by side, and yet we still also are independent and respect one another. That I may come to them with something, and I'll say, why aren't you guys doing this? Because I'm telling you, my groups is, they need this or whatever. And then they'll say, Sue, here's the deal, and then when you listen to somebody else, then you go, okay, I get that. Then I have to go back to the group and say, guys, the treatment center can't do this because here's their boundaries. And so it's a nice way to kind of be that middleman, going back and forth and understanding one another, and trying to find a solution so that everybody wins.
Mm-hmm. And I guess going into that financial services, I'd love to hear more about your financial support programs that you have and how it's kind of worked with the HTC. I know when setting up for this call, we briefly touched on gas cards and reimbursements and that tricky relationship between your HTCs, where it's different for states. Some states you can, and some states you can't really reimburse travel, or there's additional barriers. How did you go about setting up what's the reality of having a financial assistance program, even one that, maybe not, how is it in South Carolina?
So, we've always had a financial assistance program from day one, I think, or at least as long as I've been on. And you have to write grants. You have to find out where you're going to fund that. We put some of our funding from our fundraisers, or wherever we get funds. We put an amount every year, a line item, what we're going to utilize for fundraising. For our financial assistance. We have policies, procedures. People have to apply and go through all the paperwork. I have one right here just sitting on my desk or whatever. We have committee and they, approve that kind of stuff. So I think probably what a lot of us all have financial assistance programs. But through the years, we worked with our social workers, and it just kind of became known that, look, we serve the whole state. It doesn't matter. They have to register with us if they're not already one of our members. So if a treatment center has somebody that needs an ice machine and they say, these guys just can't afford it, I'm sending them over to you. Will you, talk to them? Can they apply? And they have to apply for being a member of our organization, because I have to be able to have that, that member as who I'm giving this, funding to. We don't give any funding to the people themselves. We pay the bills, or I send them an ice machine or whatever needs to be done. And through the years, we just developed that with all 3 of our HTCs. And so we write a grant together, or I write the grant. They're part of that with the Hemophilia Alliance. And then you get a larger pool of funds. And so if there is funding there for the treatment center, there's funding for any member, really anyone in South Carolina. So once people kind of know that, then they'll utilize that if they need that service. And, we provide that funding until we run out of money. And it's really about kind of where that is. And then we normally go a little bit further than that. If there's a need, we literally have never turned someone away until this last year. We ran out of funding at the end of the year. And because the decrease in the funding that I'm seeing for to the chapter, like everybody else, was the first time I had to start telling people we are out of money. And that was a very painful thing to do. We're just waiting for our grants to come through, because we can't keep pulling from our reserves, because I'm afraid, our reserves will continue to go down, unless it's something that's just, really has to be done, and we need to do that and take that risk, then, we'll approve it. But it's been a great thing working with HTCs. They're social workers, and we get our home care companies that have patients that they see on their service. They'll say, are you a member of the chapter? If you're not, you should be there anyways. And then those patients will also, ask sometimes if they need assistance. But ours it started out really not tight, but we had definite, things that we, gas and, electric bills and all that. But through the years, and especially now, if somebody has a need, if it's a life, a life expense, if it's, we have people that, sometimes I even paid someone's taxes on their house, because it was a trailer that they lived in from that they got from a long time ago from the AIDS crisis. And this was all they had left of their father. And they did not have the funding, and that trailer was going to be, it was a mobile home. It was going to be sold. And so we paid the taxes on that to get them up to date. So it just kind of depends what the need is. And if it's legitimate and we kind of know the community, then we'll pay it. And it's a blessing.
And I know you have similar programs. I'd love to hear about how it works in Lone Star.
Yeah, it's very similar. It's called our Helping Hands. They go through their social worker for the referral. They send it over to us. Same thing. We get a lot of new members that way because then they connect with the chapter. We don't pay the patient directly. Same thing. Pay a bill, a gas card. We do provide all of our HTCs gas cards to have on hand as well. For someone, says, I can't come to my HTC visit because I can't afford the gas to get there. I've got to drive 2.5 hours to get there and I don't have the gas. So the social worker, most cases, I mean, there's a couple cases that this won't work, but they do ask the patient to get to the treatment center first, and then they reimburse them for the gas card, because if we give them the gas card and then they still don't show up, then they have the gas card and they still haven't had their visit. But we'll also provide gas cards. For example, we had just a couple weeks ago, college student was coming home from college for his yearly visit, but he's in college 6 hours away. So we gave a gas card for him to come to his yearly visit to make sure he made it. We also have a partnership with one of our HTCs is located down in the Med Center in Houston, and hotel right next door, and they've contracted a medical rate at the hotel. So if someone has to be there at 8 in the morning for an appointment or for a procedure, and they're 3 or 4 hours away, they don't have to leave at 2 in the morning to get there for check-in and park, all that kind of stuff. We'll provide a hotel room the night before for certain mileage away.
That's awesome. And that they made the
Mhm.
relationship. Yeah, that's really cool. I haven't heard that before. That's really cool.
Yeah. That's really amazing. And I guess like how does your Sue, how does your financial support tie into your rural technology program? I know it's not an official program, I think, from our discussions, but it's something that you've done over the years to bring access and telehealth to rural communities in your state.
Are you talking about our VIP program? The
Maybe.
so this was really, really super cool. So long story, I'll try to make it very short. So during COVID, like, when everything shut down, we were like, how are we going to keep our community together, right? It's like everybody else. So we decided, and I can't remember if it was part of our big Hello conference. So with that conference and that sponsorship funding and in our funding that we put into that, I bought I went to the Apple store and I said, hey, here's our issue. I need a bunch of iPads. How do I get those? How could we do that? So we kind of worked out a deal with them and got Apple iPads at a little bit of a discount rate. But then what was really, really cool was they turned me on to a system it's called a managed device system. It's like in any other company that has, iPads that are, managed through their company. So ours is called JAMP, JAMP. So what we have now is we have 85 iPads that are out in community hands, and we can put information directly onto those iPads. So we can put URLs onto them, little icons, and we put on the face of it, we can put the face of it, we can say, hey, here's what's happening now or whatever. So people can just link on right onto our iPad. So those that they have to have internet, obviously, but those that are in rural areas, we can even turn it on in Spanish. I don't have Spanish speaking community members that have them, did not want it in Spanish. But that really, really helped so that they can use that for telehealth, but they can also use that in virtual technology to attend our events. But that was, I think that's actually one of my proudest, it's the most complicated thing I've ever done, but I think it's one of the most proudest thing that I think that we've done for setting up in that time and making sure that our community members are connected. And, I could literally if somebody were to call me and say, hey, I need a form right now, I could literally download it, put it into the system and say, here, it's coming to your iPad, like as one individual, but we normally do everything as, all 85, but I can actually send stuff to them. I could turn it off. I could find where they're located. It's a pretty complicated, but cool system. But I think that's something that I'm really, really proud of. And that came out of necessity.
Yeah, I guess looking at that, before going into Q&A, I'd love to, know if there's anything like any programs you'd love to cooperate with your HCC on, looking forward. Things like that I think would be amazing for telehealth, especially in states that have a large distance between maybe where the HCC is located, maybe more rural individual states that may be more stratified in terms of where the populations live. Looking at the future, are there any programs that you'd really love to create, or any areas of need that you think are going to be the next, big frontier for your chapter organization?
That's a little harder. Our HCCs actually are reaching out to the more rural areas. They've got 2 more sites that we call them like travel HTC visits or whatever, like 4 times a year in some of the more rural areas. And I guess they borrowed, clinic rooms or whatever at some of the hospitals. So I attend our HTC visits as part of their staff whenever I feel like it. I would love to be able to get out to those HTC and maybe like do a lunch. I'd love to do like a lunch and learn during the HTC visit when people are coming, you know, before they leave. I just haven't had that time plus that funding to provide that lunch for them, but I think that would be really cool.
Yeah, that would be cool. We do, our HTCs do something similar, the satellite HTC visits.
Yeah.
Texas, and we're working hard because some of those people are not connected to the chapter to get them connected, get them to camp, things like that.
Amazing. Yeah, I'd love to turn it over now to Q&A and really encourage anyone to bring forward any questions they might have or bring any ideas that they have to improve programming for community members, whether that's telehealth programs like the ones that Sue developed during COVID, better programming for Spanish speaking communities, or any questions they may have for Mark or our wonderful panelists. Yeah. I'll
I have
see
one.
about.
Oops, sorry. I
Oh,
do
yeah.
have one question that I want to ask that we talked about earlier, was the ability, and maybe Mark knows there's a legal thing or whatever, but we were talking in the chapters, and as Melissa said, to be able to bring from her program to bring cards or whatever, gas cards or whatever, to the HTC for them to hang on to for when patients come and they can get there, then they can give them the gas cards to go home. Our HTC is not comfortable with me giving that to them because they don't have the, like, who holds on to it, where's the legality part of that or whatever, because it's funds, right? But it creates a barrier for me to, if somebody calls and say they want to, they need money for the treatment center visit, and if I'm not going, then it's like, we get it to them beforehand, but they need it on the way home. So I would love to open up that conversation with everybody. If you are able to do that, like Melissa, how is that done at one treatment center where it's okay, but not at another? Like, because I think I would love to be able to say, here's a bucket of money or here's a bucket of cards. Tell me who receives them, send that back to me so we have a running record of it, because I have to have a record for where the financial assistance goes. Is it a work thing? What it is? I'd love to open that conversation because I would love to have help to find a solution for that, because that is a barrier for us.
Our social worker manages it at each of our HTCs.
So you give it to her and then she just hangs on to it in her drawer or something, or?
Yeah, lockbox, and then she keeps record of who she's given it to.
Okay, that's awesome.
I'm gonna jump in real quick as a patient who's been at a treatment center for 50 plus years, and understanding that many treatment center staff are also involved in research and the expansion of the patient bases and the legalities. What I would suggest, I've seen in chat where the gift cards are sent to protect everyone. If Johnny or Susie's due at the clinic by 10 a.m., FedEx it the day before to where it's signature required to the desk. Because with all that, the reception area where one checks in. The reason why I'm suggesting that, with so much that goes on either in a comprehensive visit or a planned clinic visit or an unplanned, that additional piece of documentation may take 2 to 5 minutes, yet in the grand scheme of the staff having to do their notes, manage calls, manage other things, that 2 to 5 minutes may seem small, yet it's impacted what they're not able to do. So shifting the ownership to say, the power balance, okay, Johnny, Susie is going to be at the desk. Here's the tracking number. Here's who signed for it. So that way there's accountability across the board. The treatment center know it's coming. They'll alert the front desk. The patient that's coming will know it's coming. That way there's communication across the board. And then treatment center staff might not be feeling, here's something else we have to do today, and we're already at capacity. That's part of the realities. Just throwing it out there. Part of the reality. Just throwing it out there.
And I saw Michelle, you took yourself off mute.
Oh, I was just going to say we do the same thing as far as giving them to the social worker. It's the same people that are running our uh, financial assistance programs. And then they just keep a list of it. And then that way they have them there. Because again, since COVID, we don't, a lot of our admin people at our HTCs are not in the office all the time. So that way they have them there. They know who's coming to visit because that's part of their clinical visit. So then they can, and they know who's asking for the assistance. So it kind of runs through them.
It seems like overall it seems really general to have that, sticker on them, asking for outreach to the chapter or mentioning that the chapter donated them as a way of getting, that connection. That seems like a really great idea. Yeah, I would imagine that it is maybe the list of people using them probably is probably not able to be given out. But it's really wonderful to see that this seems like it's a national process that is going on in many different states, from the Pacific Northwest to Texas to South Carolina.
I have a question. So on the cards, are they like a gas card to whatever, BP, or are they Visa cards, or how does that work? Because everywhere I have a problem with, there's different areas. I don't know where someone's going to get gas where they would be living. So I'd be curious to know how that is as well.
So Sue, we just did the gas cards to like the gas station that's closest to the HTC because I had that same issue. All of my people are coming from different places. So I just did the gas station that was close to the HTC. And then and thought the fact that they would realize that they probably, if they didn't have that kind of gas station near them, then they would need to get gas there. But I had the same predicament. I was unsure what to do, and that's just how we did it this year.
That's a great idea. That's a great idea. So they have to get there and get their gas card to get home or whatever. That's a great idea. I've done the gift cards of MasterCards and stuff like that, but I do like that idea. Thanks, Brooke. Nice.
I'm joined today by Bobby Weissman. I'd love to give you a chance to introduce yourself with a quick snippet, and then we can go into some questions.
Well, quick snippet because you asked. Good afternoon, good morning, evening, depending on where you're at. Bobby Weissman Jr. Here in lovely Sacramento, California, person with severe hemophilia B, technically on paperwork. However, now going into my 6th year of gene therapy successfully. Parent at 32 because I was a foster parent. I am a grandfather as of January of last year to a lovely 1-year-old now, and I have 2 more grandkids on the way. Other than that, it's a normal day, and I have class later on this evening. Hello, all. I gave you a snippet as I could snip, Adrian, and you know this from our phone calls.
I appreciate it. I really think we'd be really good friends, Bobby. I'm currently having my computer supported by a bunch of comic books, so right there with you.
Yes.
Thank you so much. I guess I just really love to go into it. I mean, based on your experiences, I'd love to go into just kind of how you were diagnosed and your experiences with clinical trials or in maybe barriers to care. Really discuss, based on your experiences, how you think that treatment practices could be improved, or any specific instances that maybe stand out to you that you think will be worth highlighting. Just laying down first a good background, and then diving into, specific issues that you think would be really important to touch on.
Okay, Adrian, that was a packed question, and you and I both know how
I
this
know.
went today. So I'm gonna behoove on you to drop that in the chat for me, and I'm gonna be me. Okay, seeing as how we're gonna have to pivot. So, is that the Rachel who I think it is? Rachel, I'm seeing a picture. Is that Camp Rachel? Anyway, she'll know who I'm talking about. But anyway, I'm gonna give context and my disclaimer. Okay. My following statements are my statements of experience. They are not endorsed and or paid for in any direct and or indirect way by anybody of any company, shape, size, or form. Let me be me. To answer your question in the best way that I can, it's about the journey, the decisions, and the process. And I'm going to say it this way. So I'm going to suggest those of you who are in your home offices, at home, at work, get a pen to write this part down, please. And if you have your pen to write this down, please put your little hand in the Zoom window thing. Been zooming all day or something, so I know you have your pen, pencil, something to write with, your keyboard, something. Let me see it in the little thing that you got. Or Adrian, if you can see, if the folks have a hand up that they have a pen, a pencil, or something, write this down. Choice. CHOICE. And then I'm going to ask you to spell choice backwards and put it underneath that. Now, if you look at choice spelled CHOICE, it makes sense, correct? Okay, y'all, I'm an interactive type. I need some feedback here. I need these faces or something, or in the chat. This is me. Okay, so we're gonna work with this. So there we go. Something in it. There we go. Thank you, Omar. Choice makes sense. We're used to it. We're used to treating protocols. We're used to product. We're used to availability. We're used to shortages. We're used to insurance challenges. We're used to navigating systems. When you look at choice spelled backwards, it's a conundrum. It's tomfoolery. It shifts the paradigm. That's the essence of clinical trials across the board. Because you're making a choice to go into it. CHOICE. Yeah, I'm country, y'all. Y'all who know me know I'm country. Okay? You make a choice to go into it. You make a choice to hear the information, comprehend the information, and then sign on that final IRB, Institutional Review Board. Then you're in the trial, whatever it may be. You're in the process. What was normal is shifting to unnormal. It's the backwards choice, but you still in it. And you're trying to unscramble the words to where it makes sense. You're trying to unscramble to scramble life so it gets back to what you want it to be. The question has come up many times around clinical trials. What would your life be without this? And that question has come before a trial. No one really can answer that because the normal CHOICE is, I'm used to this. I know how this works. I don't know how it's going to be with the whatever from the trial. At point one of going into the trial, the efficacy of whatever the thing is may start to take effect. You still might be in CHOICE because it's normal. But as it's going along, walking along, there's a shift. And what you normally could do under choice, now you got to think. Everything's scrambled and jumbled from a medical side, plus the life side. Okay, so here's an example. Let's say, June 2018, someone might have gone down to their local treatment center, went on to the coldest part of the hospital, laid in a hospital bed, and they stuck a vector in them. Everybody in the room, hematologist, nurse, and all whatnot, waiting with bated breath to see what's going to happen. Somebody laying in the bed asked the question, when y'all going to put in this gene therapy thing? We already did it. In a blink of an eye, the push of 510 cc's, a changing moment. What would happen after there to the next 5 years was uncharted territory. Along the way of that uncharted, there were conversations both with community. There were conversations also of faith. Notice when I said conversations of community, I did not differentiate between providers, friends, family. Because being 50, I'll be 53 in June. So the world I grew up in, it was all meshed together. Where came out of UC San Francisco with Dr. Marion Cooper, Susan Karp, the nurse. And so all the families knew each other, summer camp, all that. So it was not an individual conversation. It was a collective of family, both biological family, family of choice, and community of choice. Fast forward, let's just say somewhere, 2019, pit potting around the house doing a dad type thing, on the Saturday cleaning the gutters. Oh, you go boom. It's like, oh, normally you go treat. However, if your levels have been going up and up and up, you cannot do your normal thing of choice. You have to stop and think, oh, I'm normal per se. So what am I supposed to do? Call back to the treatment center, say this is what's going on, and develop the protocol and process because it had never been done before. Then you got to sit there, twiddle your thumbs, and figure out what the HE double hockey sticks to do. I'm changing my language real quick. Some of y'all know I could say it a whole nother way, but we're being recorded, so I can't. And then you got to sit in that moment of going, this is not what I know. I know what to do with this, but I can't do that because it could mess this up.
Mhm.
Then there's a shift in the relationship where even with the clinical team, you're going, what do we do next? What do we do next? And it's a different type of conversation, a different type of choices. That's spelled the CHOICE because it's being worked out. Not the confusing way, but saying we're going to take this off, this off, this off. Then what we can do here. Then you're rolling along. Then something non-medical may pop in, but heart-based, head-based. Then you say, this doesn't make sense. I have 50 plus years of experience that says this is what should be. How do I deal with this part here now? Where is my place in all of this? Where is not my place in all of this? Where do I reach out to in all of this? Then you skedaddle a bit more and you have one of those weekends that's 7 days backcountry backpacking. And you have some of the family members who might say you got your factor to take with you. No, because technically you don't bleed. But you have your trauma dose there with you. You get back from that lovely 7 days in the backwoods. Come on home, shower, because it's necessary. Week later, you're doing something around the house, you stub your toe. 3 days later, your toe is still toeing and it hurt. And normally the body would self-do its thing, but then you got to call the treatment center and go, my toe did X, Y, and Z. Get some labs done and check things. You might have to treat. And the question then that comes from the nurse, do you know how to self-infuse? Considering 5+ years of gene therapy, 5+ years of a long-lasting product. So in essence, 10 years of not having to self-infuse. And then choice is backwards again.
Mhm.
So that's a long answer to your question about clinical trials and the process. It's never the same across the board. Yes, that there is a protocol in the practice. Yes, there is paperwork. Yes, there is consent. Those 59 gazillion pieces of paper do not contain the human experience. They do not contain that on day one set of things are going on. By day 5, there's something totally different. And the part of being in the clinical trial is understanding that and being open to saying, okay, I can deal with this on this day, and standing your ground and saying, no, I cannot do this on that day, with some of the requirements that may be imposed onto you, be it travel to a location, be it this, that, or the other, and saying, I have to balance my life in conjunction with this. And I don't have the bandwidth to deal with this today. I just don't. And to say that and be okay with it. Then the other side of it, this is me personally. I can't stand all that paperwork to read because I don't read it all. It's just too much because it does not capture it all. Yes, there's cute tables and all there and whatnot will say what's going to happen this week, that week. That don't matter to me because after the thing was done, it's like the light was like, huh? What do you mean? I expected something else. I saw what this said of the frequency, but the reality was different. So the expectation, anticipation, and execution, plus with life, yeah, that's all I got for you now.
No, that's amazing. No, that's really amazing. I was talking with a woman who works at a rare disease organization. They're on the pharmaceutical side of it, and she was shocked when she learned that the consenting form was 53 pages long. She was shocked when she learned, everything that was being added and was continued to be adding to the consent form. And she was worried about the fact that the people who were being given this form, people, I think in this case, it was specifically for older individuals or individuals who have memory problems. And they were specifically being given this treatment. And she was wondering how it would possibly be that someone who has memory problems, someone who can't see, in this case, would be able to consent. And the reality is they wouldn't be, right? They wouldn't be able, with 53
Correct.
pages, with bad eyesight, how are you able to, read this huge document, And that commitment you said, of 10 years, right? 5, 10 years. For your gene therapy, what was the reporting like? What was the reporting time that they gave you that you'd have to keep reporting on? I know in some cases it's pretty long. It's like 20 years in some cases.
In the trial that I'm in, I'm on the 5-year extension. So I finished the year 1 through 5 and signed back up for year 5 through year 10, long-term study. So that's
And
on
is
that. Mhm.
and is it you signing up, or is it them saying we need more additional data?
Now there was a two-way conversation on that. That when I was had year 3 of the initial phase, I asked the question, "What's going to happen in year 5?" And the questions I asked, "What's going to happen in year 5? What if the levels start to drop? Year 5, year 6, years, et cetera, et cetera. What would that then mean for a quote unquote retreatment? Would that be retreatment commercial market, or would that be retreatment under clinical trial setting?" Then there were other questions, long-term efficacy, that there was no answer at that time because it had not been done before. So when we're getting closer and closer to year 5, with the treatment center staff, we had the conversation that they're in the process of developing the long-term study, and that I would have the option of going into it if I wanted to. And so we had that whole conversation and signed a whole new set of consent forms.
Yeah.
And I will say it this way. I read each and every line of the consent form, and there was a post-it note where I needed to sign. That's all. That's the only thing I really read. Right. That's it. That's it. It's just it. And to that piece, and I'm trying not to say it, but I'm going to say it.
Yeah.
Clinical trials are created in order to have an effective change. I understand that. Yet when the system does not understand the population it's supposed to serve, and it keeps creating and regurgitating the same thing, it makes no sense at all.
Mhm.
Is that, especially if you've got a population that might be sight impaired or they're cognitive challenged, and now this just will not work, and if they were unwilling to put in an adaptation, have it done from an auditory standpoint or some mechanism to where it is meeting the patient population more effectively. Just because a process has been in place for years does not mean it's always correct and right. And that becomes part of the challenge of bridging the gap between access and application of whatever the trial may be, regardless of gender, regardless of ethnicity, racial identification, finances, all of that. Because across the board, if the person cannot understand the information, have it explained in a way that's comprehensible, and have it fit with life, then we got a problem. Systems were created, okay, cute dandy, but you're working with a person that's not a system, that's an individual. And many of these things are set up that, oh, we need this, that you got to read this. That in an hour visit, you cannot comprehend or go through 50 some odd pages that's at a 9 Roman times font. You cannot.
Yeah.
And there's an expectation. No, you cannot. This is something that is changing one's life. We're not even going to talk about if the trial is not effective. That's a whole nother set of psych social, but I'm going to keep going, Adrian.
No, well, I have the question because it seems the point you made about systems not being in place. It reminds me of what you said about year 3, where you said, "What happens if this isn't effective in year 6?" And their answer was, this is me. This is what I got from what you said. Their answer was, "We don't know, and this hasn't been out long enough for us to tell you what happens." So you then signed up for additional monitoring because that's what logically makes sense, right? I guess we go back to year 1, right? Was that year 3 question on your mind? Was that like year 3 like mindset of like, are the systems in place? I guess I'm curious about that year 3 question of what happens year 6. did they tell you about that in year one?
No. And where the year 3 question came up, quite honestly, is because one of the kids was saying, I'm going to get married. I said, okay. And then she said, I'm going to give you grandkids. I was like, okay. And so my mind was thinking grandpa head. Like, okay, I want to see what's going on and be able to run around with the little rugrats. Yeah, that's where I was at. And so the question I began asking in year 3, what happens here? What happens here? What happens here? And the comparison that the treatment center had was other disease states that had successful gene therapy. And they compared, the data of that. So there were projections and estimates, yet it was not really known. Now, also remember, I'm hemophilia B, not hemophilia A. So our population was a whole lot different as well. So it was, kind of like, I'm a Star Trek fan. Yes, I am. Star Trek model, explore, strange new worlds, all that.
Yeah.
So literally explore it along the way as we went along the way, figuring it out. Yes.
Yeah. So I guess this is a a side question, but your gene therapy trial, you mentioned your hemophilia treatment center. I know when talking to other gene therapy trial, people associated with them, there's a lot of discussion about how some centers can't handle it. They won't be able to administer it. They won't be able to do it at smaller centers. So there's this idea of hub and spoke where we'll have smaller HTCs refer patients to larger HTCs. Did you have to go far for yours, or was it just right there at your usual HTC?
I was at the usual HTC now, where this is where it's simple complication, meaning that yes, the clinical trial was done at UC Davis. However, that's a separate piece of the treatment center. So there's a research coordinator, there's a research nurse that's aside from the adult nurse. Okay. And so there's a different set of labs that have to be done for the gene therapy, which means that those labs were drawn in the clinic visits, the gene therapy clinic visits, which also meant that if when I had my regular HCC visit, a different set of labs were drawn. The labs for the clinical trial could only be processed at the laboratory for the trial. Okay. So what your question is alluding to several things: the infrastructure of the treatment center, and the lab location and time. That I was, for the first part of the trial, I lived about 30 minutes away from the treatment center. Then with the family, we relocated an hour and a half away. And so that meant literally once every 3 weeks, I was down at the treatment center for half a day because it was
Wow.
lab work. It was, the half a day was like an hour and a half down, hour and a half up, an hour for lab work, filling out questionnaires. It is labor intensive. Yes, it is.
Yeah.
And there's blood specimens that are collected and other fluid specimens that are collected on a consistent schedule. Fill in the blank yourself, folks. And so doing all of that, and the treatment center was able to work out with the funder of the trial to put in the transportation piece, because I had to be able still to work. So to get me from home, work in the car, do the visit, go back. Right. So there's many nuances. Then the other challenge can become in that spoken hub of who is the primary in that model. That if there's a smaller treatment center and larger ones, who's fully monitoring all that care? Because there's so much paperwork in it and reporting. If I decide to add a herbal supplement, I have to report that still. And so that it's tracked if there's an adverse event or anything. There's a lot of documentation. So that's all the way around the mulberry bush for you. But it's a teeter totter, because for some folks they have to make the decision around gene therapy, not to do it as in terms of family planning, because for a while there, while in the early phases of the trial, or the vector you want to call it, you have to use safer sex practices with the condom. And so if you're trying to start a family, that may be preventative. So then you have to make that decision.
Oh. And I mean, I don't know how it is in Sacramento compared to, like LA or San Diego, but I can't imagine California traffic is very, sympathetic to traveling an hour and 30 minutes.
It's a piece of cake, and out that go 82 miles will only take 2.5 hours. That's it.
Oh my God. Um, well, I guess my, a follow-up question is, did you have support from your local chapter? And if you could have support from your chapter, what would it look like? I mean, in a perfect world.
Would you like me to give a politically correct answer to that or a reality answer?
I think we could all go for reality.
Reality? No, not at that point. That where the support came was from the family, my mama, the church family, and the research team, who was also the treatment center. Now, what you have to understand out of the Northern Cal model, I was former camp director, one of the three. So the medical staff, I knew them already. So as the process was going along of doing the gene therapy and actually in it, there were still conversations going. So there was not involvement per se from the local chapter. All four of the treatment centers from NorCal knew what was going on because I was the guinea pig. That we had running jokes if I was going to grow another foot or toe, literally, because we couldn't figure out how to process it really. I'm being real with it. There were running jokes that while after the vector was done, the first hemophilia treatment center nurse I had called me to see how it went. That's how connected it was. If you get where I'm going, and the support really came from community and family, the church, and the research team because it was close monitoring for literally like 6 months of everything. It was like old school hemophilia treatment center model where was on demand going into the ER because it was so new and want to make sure all the T's crossed and I's dotted. Would I give that up or go back if I could blink my nose and go back and change it? No, because what it's allowed me to do since then, and both physically, mentally, and heart wise, that it as I said it earlier, that it shifted some things around. That no, I didn't have a liver transplant or anything of that nature. I've never, I've only had one joint bleeding in the life. Mine's typically been muscles. So now it's just like, oh, where is the place that I would fit per se within community? If that makes sense. And
That
this is
does.
even a conversation I've had with the social workers. They're like, we don't know what to do with this because our folks who are like on Hemophilia who are now fine, they're cured. And our folks with the liver transplant, y'all are a whole different bucket because the system that's in there was created for a valid reason. The system, some components are changing, yet not the system yet. To where I heard in part of the great discussions earlier about really coming about access and expansion into community, yet dwindling resources. Part of that might be partnership with other like and similar organizations, where there's those ties and binds of community and the quote unquote demographics that are checked that build stronger long-term relationships so the system is able to evolve, meeting the needs, and that there's a sharing of resources. So sorry, Squirrel, that's the other side of what I did. Okay, back to your question. Yeah, I'm being good, y'all. Y'all know, some of y'all who know me, y'all know I'm being good. And I'm trying with you, Adrian. I'm trying. I'm trying. Yeah, if you don't open this up soon for some questions, Adrian, I'm gonna do it myself. Okay.
No, I would absolutely love some questions from the audience, and we can definitely go into a more gallery view to bring in those questions. It's a workshop. We really should have. If you can unmute yourself, I'm going to take off the spotlight, and we can really think about how we can improve that community support. Sue?
Yeah, so, wow, that was fascinating. So, Bobby, number one, thank you for being the guinea pig. I've said this many times on many things that I've done. When they came to my children, it was just they were factor 9, and they came right when Benefix came out, and there was like, trials between mono 9. Like that was all there was, right? And I was like, I'll do this, but I won't do that because I was too afraid, right? So it takes guts, and it takes somebody to be the guinea pig. So I always want to say thank you to people that do clinical trials. This guinea pig, for what you did, was humongous. So I think that a lot of the stuff that I heard you say was fascinating, and I appreciate the honesty because I think it's important that we tell our community honestly what things are like. But I'm hopeful now because you were the first, the first in the clinical trials, all that kind of stuff. There was all that first. So now you're past all that first, so that when we come into, now it's not, clinical trials, but it's FDA approved, it's a different level that maybe the systems will be a little better put together, but probably not a whole lot because we as the treaters and the community weren't part of that. So when you talk about the chapters, not like the chapters couldn't be a part of that because it was kind of see, you know what I'm saying? So now we all have to find our place. Like, wow, so we have somebody that's possibly going to do that. And I'm like, oh my God, wow, what are we going to do for that person? Or how are we going to make sure, should I reach out every once in a while? I mean, there's a lot to that. So I do appreciate your honesty there. And it sounds like it's enormous, but my question for you, but you answered it, was given what you went through and what you know now, obviously you've said that your life is much better than it was before. And that's that's a grace of God that you're in that position. So thankful for that, for the people that made those clinical trials, but thank you for doing what you did. It was a fascinating conversation following you. So thank you.
And yes, so for the part of the clinical trial that I was in, there are three of us total. Okay. The three of us have met on a consistent basis in an advisory group capacity. Notice the air quotes. Okay. And I'm going to say this quite openly. I'm a Black man. Let me be very clear. Okay. Some of y'all may not know this, that I'm a Black man. One of the individuals in there is a white man. Then the other one is a middle-aged 20-year-old college type person. Okay. And what's interesting is when we get on these calls and are talking, the three different experiences. One person has never been involved in local chapter stuff, or not really even a treatment center, just getting meds, good to go, living life. Other one, young into college. Me, some of y'all know summer camp, NHF, HFA, coalition, international stuff. And it's interesting that we're talking about access. The three of us did not know each other from Adam from Eve before the beginning of it. Okay. And we didn't know there was only going to be three. Now you all know him for the population. Okay. Yet we've become so tight in the process because of what we went through as guinea pigs. Okay. And we say that with love on the guinea pig, because we're like, look, we'd rather do this than what we were doing, because what we were doing was a cure, but we're like, let's go ahead and try it. Why not? Because some of y'all know I can just say to hell with it. Let's just do it. For the simple fact that something you said to my granddaddy and mama said, if you can do something for somebody else, do it. Because this very same community is the set that poured into you when you was a kid with some various things come on. Never forget where you come from. And that somebody's got to make a change in the difference. Somebody. That there are times that there are somebodies to do it. That's collective. And to the part of where the chapter comes in or the treatment center, because there is a separation when it comes to clinical trials, is the psychosocial and mental health support. And it's not the flowery DSM-10 and all that. It's like, child, how you doing today? What's really on your heart? What's really in your head? That type of conversation. Because there's a cluster boo-boo. It truly is. If you understand what I'm saying, it can be. That if it can be. And the other piece to add into there with the trials is also the treatment center staff. Because there's a paperwork burden. They've seen where folks are at point A, point B, and they're going into something. And not to deny that personal connection, that they also need support in all of this. Not just the patient basis and chapter folks. I'm gonna leave that alone for right now. Okay, thank you for flying Air Canada. I'm being good, Sue. I see your face. Right.
I'd really love to ask some of the HTC people on see if they've got any thoughts on this. I can see Cara from the Arkansas HTC. listening to these conversations, how do you feel listening to, today's sessions, and especially what Bobby's saying about gene therapy?
Can y'all hear me okay? Can y'all hear me?
Yeah.
Yes, we can.
Okay. Thank you. No, I really appreciate you being so honest about what your experience was, and also pointing out a lot of the things that go into planning that from a systems perspective, and how there's a lot of things that sometimes systems will just do things over and over again, just because that's how it's been done without any real thought for how it impacts patients. And so hearing that as a social worker, it just was really validating to hear your experience and know that going in and seeing the person, picking up and meeting them where they are and what their needs are, and as individuals, is what is needed. So.
Thank you. Now, Kara, I'm trying to be good. I'm trying, but I'm gonna say this, and thank you. Silos have got to go. They've got to go. And the reason why I'm saying silos have got to go, there's too few of us's for what needs to get done. As the example Sue gave earlier of the young lady with the insurance problem. Common sense would tell whoever's the CSR on the phone at the insurance company, look at the file. But things are done as a computer, no common sense. Where there's a separate, the humanity is gone. It's just gone. It's just gone. Where it's like, no, not my responsibility, not my problem, ain't gonna worry about it. That there's an innate connection and passion within all of these communities, okay, of getting stuff done, of having an adverse situation and fixing that girl to where it worked, okay, and changing the paradigm and saying we cannot deal with this way. This is what's needed and necessary. Part of the and part of the silo-ness is because of money. That this is my pot of money, this is yours, this is my, the money gone. Okay, cute, but the people are still there. Let's have a conversation of how we can work in true partnership, in true collaboration. Yes, we understand legalities. Yes, we understand spheres of influence. But if at the end, we have to keep in mind, what is our goal? If we focus on what the goal is and work in true consensus and collaboration and community, we'll get through all the muckety moo. It may be some headaches, yeah. It may say we have to shift our entire model, our entire vision of how we gonna get there. If where's the there we need to get to and there's stumbling blocks, okay, get the bulldozer out, move it out the way. Make it a new way. That's simple. If you keep hitting your head on the wall ain't gonna move. Change the way you're gonna hit your head. Go the other way. All right, I'm sorry. Adrian, go.
No, I think you're absolutely perfect, honestly. And I think it's really neat. We need, like, you said, removing silos. We need your voice in this, right now, to discuss what the actual experience of, patients and community members is in having, and accessing care, in dealing with everything that comes with, clinical trials, in just living through it. The process for gene therapy, like you said, is, in your case, it was 5 years originally, and now it's extended to 10 years. Sorry. And in some treatments, we're hearing as much as 20 years in reporting time after, actually going through the trial. That's 20 years potentially of having to report, personal data to an HCC. That's 20 years of that relationship. That's not accounting for things like movement. That's not accounting for things like travel to an HCC, like you said. That's not accounting for life. God willing, human beings live up to about 80 years, 70, whatever the average is in the United States. And that's a decent chunk of time that's being committed to clinical trial reporting. So, hearing your honesty and hearing your candor and talking about your experience and the reality, like you said, you thought about the future and you said, okay, grandpa brain on, what does that mean for the reality of my, clinical trial reporting? I have to extend it up to 10 years now because I want to make sure that it's still effective. And I think it's something we have to keep, we have to consider, especially when it comes to the, HTCs on the call, especially when it comes to the member organizations on the call. I'm looking out, I can see individuals from all different, sections of the bleeding disorder community. And I think of how important conversations like these are, because the solutions that will come out of this workshop will be ones that bring in everyone together. And there'll be ones that involve, your lived experiences, that time commitment that comes from gene therapy, that comes from clinical trial participation, that support from your community, and the reality of having to deal with those 50, 100 pages of the consenting form, and that demand that it calls on you, and the financial burden as well.
Yeah, I love that lovely, good recap. And I'm looking over your head because I keep seeing impact behind with a little drop thing. And my wordsmithing self has an issue, and I'm going to say it. It says improving minority participation, advocacy, and clinical treatment. My thing for me is IPACT, improving participation, advocacy, and clinical treatment. The reason for that, I'm of the old guard, way old. I'm old school, typewriter old school. And that community was not divided by a term, it was community. I understand the need justification, but I'm just throwing it out there that if we're talking about really improving participation and advocacy in clinical treatment across the board, to be conscious of the fact that one could be, quote unquote, a minority with $1 million budget and $1 million in a bank account. One could be a minority due to the amount of melanin or non-melanin in his or her self. One could be a minority if one is LGBT trans in some locations, how one is treated. To be very cautious and careful of how we're defining things, because that also has its way of shutting and or opening doors. I'm just throwing it out there. You asked me to be me, I'm just being me and saying it, because that can create, when it's that some may look at it, oh, it's only for minorities, but how are we talking minority? Okay, if I ride the bus versus got a Yugo or a Honda, okay, I'm just throwing it out. This me. I'm talking as me. Is to look at that. And my example to that is with my treatment center. Right before therapy, the question was asked, are you ready for this? And I gave a knee-jerk answer. And then social work and the nurse looked at me and said the following, boy, what's your damn answer? Just like that, person to person, and gave the real, you catch the difference between the two. So the clinical role came off of all three of us and had a real conversation of some real connection. That's something, that the difference of wording, that is that piece in that. That's it. Go on back, Adrian.
No, I 100% agree. When I go into my clinic, and my physician, who is also a man of color, just gives it to me straight. He tells me that to calm down. He tells me exactly what's going on, and it's neat.
Okay, and you just remind me. So as I alluded to, with the gene therapy trial, you have to produce a sample. Mind you, I'm 52, soon to be 53. I had to produce a sample. Catch what I'm saying? And the research nurse kept asking for the sample. It got so bad to the point the social worker called me and was real nice. She put on her mother voice. Boy, if you don't bring that damn sample down here by tomorrow morning, I'm calling your mama. Now, to help you all out, because I think do you all understand what I mean by sample? Something in the chat. Let me know if you understand what you think I'm saying. Let me be clear then. Seminal fluid, and to produce a sample. Let me be that transparent with, okay? There was much question to get that produced. And the social worker called, and so I had those cute little bags from the Dollar Tree, a party bag. I got me a party bag and put it in there. Okay, yes. Now that you raised, Julie, before the trial that I'm on now, I went through 3 other screenings. And in those screenings, was screened out for 1 or 2 of the results from labs. Yes, there was a roller coaster even with that, because I had gotten like really, really far in those process, and then to have a hammer drop. Um, blah, 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 blah. The part of compliance and research is uniquely different than standard HTC compliance of appointments and adherence to treatment schedule. That what I would suggest, that would take a team collaborative. That if there is a community gatekeeper for the patient or whoever it is, and someone on the team to work in tandem, because it takes a lot. It's a lot. It may seem the question may come up, well, why can't this person be compliant on this? It could be life's issues or challenges going on, and someone having some conversations with the person to see what's really going on. That looking at it from the standpoint of the social determinants of health, and to see what other services or resources might need to be implemented. So again, it's that larger team concept. Sorry, squirrel moment there. Okay, keep going, Adrian.
No, I mean, I'd love to, like, we have about 9 minutes left. Sue, Melissa, if you'd like to, come back onto camera, we can ask any final questions. Open it up really to, have that, that cross-functional perspective of, member organization, ED, and, community voice. It's really brainstorm before we go into day 3, how we can really come up with these solutions. 5 minutes, and then I will wrap us up and what prayers for day 3. If anyone has any, yeah.
I'm huge on communication, because you don't know what you don't know until y'all talk, right? So I think, we don't, we go through, like you said, we go through what we do, and but everybody's in the same boat. Everybody has the same feelings. And I think that these kinds of conversations are great because, like I said, now I've got a lot of things talked about to my treatment center. It's like, oh my gosh, we better start thinking a little bit more, preparing a little bit more, because there's a lot more going on. And I think we knew that. I was part of some panels on clinical trials, like how is that going to work? What's our community going to be like? What's our entire community going to be like? We're all, as chapters, just wondering that with, we're in a new transformational time, all of us. So it's all good. It's all good,
Right.
but still very difficult. So, access obviously to treatments and, for your sake, it's great that you got this opportunity, even crazy ride that it is. But for some that really want it, they'll probably never get it just because of the fact that there's a cost to it now. We have all those other things. So we had one guy that, and I talked to his mom, and this is like that emotional thing, but he really, really wanted this. And his mom called and she was asking me something. I said, well, let me make sure you understand this isn't a cure, right? This isn't a cure. And so we had to kind of talk about that. But long story short, she, the young man was like, well, I'm not drinking anymore. I'm getting myself all cleaned up. He was all preparing himself and his body for, he's going to go through this. Well, he wasn't a candidate because he had antibodies. And that was for his mom and for him. And obviously for me, I about died because I was like, oh my God, how can that, why would that happen to that person? So I think there's just a lot that goes on to that. So I appreciate you bringing the conversation up. And I think as a whole community, we need to be leaning on each other and trying to figure out how we can all make this, these transitions that we're into between our treatment centers, our orgs, our member orgs, our personal lives, our families, and our HTCs all as one huge group, trying to figure it all out together as we move forward in these, kind of difficult times for all of us in a way, and exciting times as well. So I thank you for the opportunity to speak and be a part of this little panel talk. Thanks, Adrian.
And as you said, cure, that word is self-defined, because some who are on prophylaxis once every 7 days, 10, they're good to go. That's their cure. That there are younger families to this day who believe and feel that gene therapy in the bleeding disorders community is a cure, that it will not come up again. Yet there's that small asterisk: in the event of a trauma, Here's what you're going to have to do. And there's all that. And then there's I had a flash. There's the part of what some things that happened in the past that have excluded some of the people from the trials because of what's still, and that whole piece of, but at the end of the day, it's all right.
No, I appreciate you both for Bobby, Sue, Melissa, Mark, all of you for coming on and speaking your truth and your experiences, and really sharing your for being honest, for really just giving the reality of it, the reality of going through clinical trials, the reality of dealing with treatment barriers, with clinical trial enrollment, the reality of running a member organization, the reality of dealing with legal barriers, and just for the honesty. As we go into next week, I really encourage everyone to come, with ideas. Come with what has worked for you, what you'd like to see done, and really think of the question of, going back to, the first day, what's your top 10 list for this year? What's the one thing you'd like to see done differently? What's that idea that you have that you think might work or that you'd like to see change? What's something you have an issue with that you think needs to be addressed? Really with day 3, it'll be all workshop based. We'll have breakout rooms. We'll have opportunity for live discussion. It will be a slightly shorter day, an hour and 30 minutes only, and not 2 hours. But it will give the opportunity for us to share ideas, share successes, share what's worked, what hasn't, and really to reflect on these last 2 days, and think about how we can improve treatment for the bleeding disorder community. So, as you look forward to next week, Tuesday, please come up with ideas. Please come with, ready to talk, and to share your perspectives. Together, we can really make a difference, and we can really think of, novel solutions, to improve everyone's, treatment and trial experience. Thank you.
And I put in the chat that y'all are peculiar and special, and in such a way of what you're charged to do with, regardless of being tired, regardless of the money not being there, and regardless of the amount of or non-volunteers. Y'all are peculiar and special and wonderful, all wrapped in. Don't forget that, and when you're making the impact on your own selves in your own houses, and keep that going, however that looks for your areas and collectively. That's it, Adrian. You had me have to pivot for the day. Right. Yeah, I can say I'm not Adrian. Stop it, Adrian.
I hope everyone has a really wonderful day, and I'll see you all on Tuesday. Thank you so much.